Welcome to the Attention Deficit Disorder Expert Podcast Series by Attitude Magazine.
Hey everyone, it's Susan Kaufman, and you are listening to Attitude Magazine's ADHD Experts Audio. Today we welcome back Dr. William Dodson for the second of a two-part series for ADHD professionals. Dr. Dodson's topic today is the emotions of ADHD, and in fact, an underreported aspect of ADHD, and he'll be talking about what clinicians need to know. A third of all adults with ADHD report that disruptive emotions are the most impairing aspect of ADHD, and yet clinicians and researchers continue to pretty much ignore the powerful emotional aspect of this disorder. Among these, the two most common and emotional challenges that have the most impact include intense emotional shifts that are often mistaken for major depression or bipolar mood disorder, and rejection-sensitive dysphoria, RSD, which is an intense response to perceived withdrawal of love, approval, or respect. Today, clinicians will learn why it's so important to include emotional considerations in the DSM-5 list of ADHD symptoms, as well as how to distinguish bipolar disorder and depression from the emotional challenges of ADHD, how rejection-sensitive dysphoria can cause many ADHDers to either become lifelong people pleasers or just to avoid taking emotional risks, how clinicians should talk to patients with ADHD and patients to their doctors about emotional challenges, and much more. So, for those of you who don't know Dr. Dodson, let me introduce him. He is a very valued member of the Attitude Editorial Board, a board-certified psychiatrist. He's been working with adults with ADHD for the last 22 years. He's a former faculty member at Georgetown University and the University of Colorado Health Sciences Center. He's a life fellow of the American Psychiatric Association and a regular columnist in Attitude Magazine. He is based in Denver, Colorado, and we thank him so much for today's webinar and for all of the work that he's done for Attitude and on behalf of everyone with ADHD. Thank you so much for being here today, Dr. Dodson.
Thank you, Susan. The whole subject of emotions and mood regulation have been pretty much intentionally ignored by research. If you look at the 18 diagnostic criteria that we have currently for ADHD, they never mention emotions at all. Our diagnostic criteria were not meant for use by clinicians, by patients. They're meant almost entirely for the use of researchers. And if you look at the 18 criteria, they really don't describe ADHD that well. What they are things that can be seen by an observer and therefore counted. And so that makes for research that's easy to publish. You can do statistics with it and things like that. The problem is that in doing so, emotions get pretty much ignored. Because one, they're not always there. Two, many times they're hidden because the person with ADHD is embarrassed by them. But most of all, it's impossible to measure these emotions. And so they've been pretty much neglected and ignored by research. And yet, anybody who's a clinician out there knows that it's the emotional impact of ADHD that brings people in that's really causing them the problem. And you see this emotionality coming out in a lot of different ways. One that gets people in trouble probably the most is the flash temper. And it's usually not that these people are terribly angry people to begin with. It's because they don't see it coming. Both with anger and with pretty much every other emotion, the expression is very impulsive. They act or express emotion without thinking, and that's because they don't see it coming. Most people with ADHD are blindsided by their own emotions. It's just out there. They find out what they're thinking and feeling in exactly the same way that everybody else does. It's there. And that's one of the things that medications do, is it gives people the same 2 seconds that everybody else has to see it come up, decide I really shouldn't express that, and to do something else with it. And people describe their emotions as changing lightningly quick. As one of my patients says, you go from 0 to FU in an instant. One of the other problems is that people with ADHD and Harvard is to blame for this. They use the technical terms. They either have alexithymia or dyslexithymia. It's literally Greek for either no words for feelings or the wrong word for feelings. More often than not, people with ADHD will use depression, anxiety, things like that, and mean something entirely different. So you almost from the beginning have to learn how that unique individual is using the words. Most people with ADHD have a very low frustration tolerance. They're easily overwhelmed by their emotions, by the stresses they experience, because a lot of times they get just completely flooded. They really don't have a barrier where they can push aside the emotional feelings of others. They pick up everything that's going in the room. And sometimes they can flip and look exactly the opposite. They can seem very cold, very insensitive, blissfully unaware of the feelings of others. They seem almost callous or narcissistic sometimes. They're exquisitely sensitive to rejection and criticism, which we will talk about in great detail. They're very excitable. They will go with practically anything. And they also experience hopelessness and demoralization because they try over and over again with the skills that people try to help them with that really don't work for people with ADHD. One of the biggest problems with ADHD is overreaction. The emotional reaction really doesn't match the nature or the seriousness of the trigger. They have a great deal of difference distinguishing between dangerous threats and minor problems. And so this is why many times they overreact, and as one of my patients says, have to be talked in off the ledge. This is one of the reasons why people with ADHD are so accident prone, or as the term in the DSM, they are dangerously daring, is that they either don't see danger and risk until it's too late, or they see danger when it isn't there. They overappraise it. People with ADHD also rarely have any peace. One of the questions I ask people, and this is after they've started on a stimulant medication, is look back over your entire life. Can you remember a period of time longer than about 5 minutes, and not drug-induced back in your wild and woolly youth, in which you've been both mentally and physically at peace? It is very rare that I have anybody who has ever known peace in their lives. It's not a very scientific term, but it is the accurate one for people with ADHD. There's also shame and guilt. Dr. Jelinek, who at the time was the head of child psychiatry at Harvard, published a study that's now almost 25 years old. But he pointed out that the average child with ADHD hears 20,000 additional critical or corrective messages before their 12th birthday. This is more than a kid who doesn't have ADHD. That can't but have a significant impact on the self-image and self-worth of a person with ADHD. People with ADHD have a real hard time being aware of social appropriateness and interactions, so they end up being socially ostracized, and as the saying goes, they are the last picked but first picked on. Consequently, most people with ADHD grow into adulthood with a profound feeling that they are less than in some way everybody else. Certainly they are uncool, unwanted, but sometimes they have the feeling that they are profoundly defective. The term you'll hear very commonly is that they are damaged goods, and just sort of generally incompetent in the world. The resulting shame and guilt often produce a situation in which negative and positive feedback is just slings right past them. They never even notice it. They're much more in tune to the negative feedback they get. Consequently, the shame almost always dominates all the other emotions. As Freud said, shame is the master emotion. It's the only emotion that doesn't seek expression, and it can determine whether or not other emotions get expressed or even acknowledged and dealt with. There is one particular emotion that is unique to ADHD. It was written about a great deal 40, 50 years ago at the very beginnings of ADHD, and then utterly forgotten. It was one of the things that Paul Winder felt you had to have in order to get the diagnosis of ADHD. But it was ignored by the researchers because it wasn't always there. It was often hidden, and there was no way to measure rejection sensitivity. If you couldn't get the paper published, then the research was never started. So the definition of rejection-sensitive dysphoria is that it's an extreme emotional sensitivity and emotional pain that is triggered by the perception. It doesn't have to be the reality. Just you think it's happened or you imagine it could happen, in which a person with ADHD feels that they have been rejected, teased, criticized, or they've disappointed important people in their lives, or that they've done it to themselves because they haven't met their own very high standards and goals for performance. They have failed and fallen short. The original researchers in this were not part of the research in ADHD. They were general psychiatric researchers, and they wanted to make sure that the intensity of this emotional pain was right up there in the name. Dysphoria is literally Greek for unbearable. It's not that people with ADHD are wimps or weak in any way. You can't be weak and have ADHD. It's that it really does hurt that much more. If this emotional response is internalized, for all the world, it looks like an instantaneous, full major depression, complete with suicidal ideation. Indeed, almost everybody who's trained in the United States is trained to see mood disorders, not ADHD. This sudden change in mood from being perfectly fine to being suicidally depressed often gets diagnosed as a cyclic mood disorder. It's called rapid cycling bipolar disorder. And also because of the interpersonal nature of the trigger, this happens from one person to the next. Very often these people get diagnosed as having bipolar personality disorder, bipolar character organization. And it takes a long time, as we all know, to do the evaluation of object relations, to find that, gee, this is a person with ADHD and their object relations are perfectly normal. And this is really rejection sensitivity. The response can be externalized as well. And when it does, it is an impressive, instantaneous rage at the person or situation that wounded them so severely. One study of people who were court mandated for anger management found that either for road rage or for domestic violence, found that exactly 50% had previously unrecognized ADHD. This rejection sensitivity also causes people to anticipate rejection. They're absolutely vigilant for it. And very commonly, this gets misdiagnosed as social phobia. Social phobia is really sort of separated out from all the other anxiety disorders in that it has a very good, very specific medication treatment. And it's an intense anticipatory fear. It's before the event that you're going to say or do something that's going to embarrass or humiliate yourself in public, or even if you are perfect, you're still going to be scrutinized harshly by everybody out there in the real world. Rejection sensitivity, again, it's very hard to tease apart, and of course sometimes people can have both. The rejection sensitivity is very interesting because it's indescribable. people cannot find words to describe the pain of rejection sensitivity. It's that primitive that it's before the advent of words. They'll talk about its intensity. It's awful, it's terrible, it's overwhelming, but not the quality. And it's always triggered by the perceived or real loss of approval, love, or respect. How do people with ADHD deal with this huge emotional elephant in the room? Many people become people pleasers. They scan everyone they meet, trying to figure out what that person would admire and praise, and that's the false self that they present to them. So much so that they actually forget what they wanted from their own lives. They're so busy making sure that other people aren't displeased with them. The other major way that people try and deal with them, and it's by no means mutually exclusive, is that they stop trying. If there is the slightest possibility that a person might try something new and either fail or fall short out there in front of everybody else, that is entirely too painful, too risky. Thank you. I'm not even going to get started. These are our slackers of the world, very bright, capable people who do absolutely nothing with their lives. I have many patients who have never been on a date in their lives. The possibility that somebody might say no, or that ultimately the relationship wouldn't work out is so threatening, so anxiety-provoking, they have never been on a date. I've had people who've never applied for jobs. I have at least half of people who never speak up in a meeting for fear that what they say is going to be rejected or ridiculed in some way. People with ADHD are very adept at finding adaptations and the positive things out of the stuff that ADHD throws at them. Many people use the pain or the avoidance of pain of rejection sensitivity to overachieve and excel. They are constantly working to be the very best at what they do. Other people have the drive to be above criticism, above reproach, and they lead very admirable lives. But at what cost? The person pursues perfectionism, which of course is never attainable, and they are constantly driven to be achieving. As one of my patients said, today's audience does not applaud yesterday's performance. And so these people never experience any peace in their lives. They never actually make it. What do you do about rejection sensitivity? It's important to say rejection sensitivity is part of ADHD. That means it is genetic, it is biologic, it is neurological. Over the last 50 years, psychotherapies have been found to have very little benefit on rejection sensitivity. It hits suddenly, and the person is completely overwhelmed, and it takes a while for them to get back on their feet. Childhood trauma can make anything and everything much worse, but it is not the cause of rejection sensitivity. It's neurologic and genetic. Very often, it just helps people to know that this is what's going on, and that it's a part of ADHD. Most people with ADHD are so shamed by it that they feel like they are the only one who has this type of intense reaction. And so they feel, again, less than. They're a head case, as many people have told them. And just knowing that they're not alone, that other people, like pretty much 100% of people with ADHD, experience rejection sensitivity, is tremendously relieving. It's not their fault, and most of all, they're not damaged. There are two possible medication treatments for rejection sensitivity. By far the simplest are the alpha agonist, guanfacine and clonidine. Again, originally blood pressure medications. They are not controlled substances. They were terrible blood pressure medications. The optimal dose can vary tremendously from half a milligram up to 7 milligrams for guanfacine, or with clonidine from 1/10 of a milligram of clonidine up to 5/10 of a milligram of clonidine. About 4 months ago, there was a very good article out of Harvard that went beyond the FDA upward dosage limits of 4 milligrams of guanfacine and 0.3 of clonidine up to 7 or 8. And what they found was they got about a 40% extra response rate. That's just one study, but again, it could be that in fact, it's very likely that the maximum doses of the PDR, we end up missing a good number of people who might respond. And that's very important because within that dosage range, only about 1 out of 3 people get that robust effect for the relief of rejection sensitivity. When it happens, it is life-changing. And I can always tell when guanfacine and clonidine have worked. Next session, when the person comes in for follow-up, they walk right in and give me a big bear hug. In terms of quality of life, it makes more difference than the stimulant did. There are, of course, side effects. By far the most common is dry mouth. There's also mild sedation. But if you lump together all the studies done on these 2 medications, the sedation was never so bad that a child couldn't go to school or an adult couldn't go to work. And a more frequent occurrence of a universal experience, something that we all have of when we stand up too quickly, we kind of a head rush, we get dizzy, vision goes a little gray. It's called, the technical term is orthostasis, and it's a blood volume problem. You can correct that one just by drinking more water. Way back when, 40 years ago, the treatment of choice were the monoamine oxidase inhibitors. We all know these from reading the backside of any box of over-the-counter medication. On half of them, there's a sentence down at the bottom: do not take this medication if you've had an MAOI, monoamine oxidase inhibitor, in the last 14 days. The MAOIs have always been the treatment of choice for rejection-sensitive dysphoria. It's only been in the last 4 or 5 years that rejection sensitivity and ADHD have been recognized to be the same thing. Way back when, in the very first book published by Paul Winder, in which it's the first time he pointed out that this ADHD was not just a problem of hyperactive, disruptive little boys. It is something that proceeded into childhood, into adulthood. He wrote that his treatment of choice for ADHD was not the 2 stimulants, methylphenidate or amphetamine, but rather a monoamine oxidase inhibitor called Parnate. Of the 5 MAOIs available at the time, Parnate worked best and was by far the lowest in side effects. Side effects are low blood pressure. You can either get agitated or sedated, and what people call confusion. Those are fairly infrequent side effects. In the one study that Winder did, comparing Parnate head-to-head with methylphenidate, they found that it worked just as well as methylphenidate for ADHD, but it also worked beautifully for the rejection sensitivity. It was a true once-a-day dosing medication. It was very low in side effects. It's not a controlled substance. It was generic. It was very high quality and inexpensive. It's not FDA approved for ADHD. It's FDA approved for depression and anxiety disorders. If you have that great a silver lining, you have to have a really big dark cloud. And the problem with all the monoamine oxidase inhibitors was that there are some significant drug-drug interactions, and also what they call the cheese reaction. Any food that is aged instead of cooked, so this is aged cheeses, soy sauce, sauerkraut, that sort of thing, are high in an amino acid found in single-cell organisms that the human body doesn't use, called tyramine. Usually tyramine is destroyed in the lining of the gut by monoamine oxidase, and if the monoamine oxidase is inhibited in the brain, it's inhibited in the gut as well, and the body turns tyramine into adrenaline. And what would happen is people would eat lots of cheese, and they would get this huge spike of adrenaline. They'd get a terrible headache, and some people actually died of strokes. So that's why the MAOIs went into mostly disuse. We now know that you have to eat a lot of cheese. You can eat a half pound of cheddar cheese in one sitting and still be quite safe with ammonium oxidase inhibitors. But unfortunately, most physicians, most psychiatrists these days are not trained in the use of MAOIs. And so that's one of the biggest problems, is to find a clinician who does have experience in using these medications. So it's right now something that's just sort of coming out of the shadows for people to use. So that's a very quick overview of mood regulation and in particular rejection sensitivity. It's there if you look for it. If you don't look for it, you'll make an incorrect diagnosis and misunderstand your patient more times than not. So look for it. It's there. You'll find it. At this point, we'll open up the mic for questions. Thank you.
Great. Thanks so much. I have to say that we at Attitude, we receive a significant number of emails from people who have been diagnosed with depression sometimes for 10 or 15 years before ultimately learning that, in fact, they had attention deficit disorder. Is that part of the diagnostic issue this is oftentimes women in our experience, is that part of the diagnosis issue that you're describing?
Absolutely. No psychiatrist anywhere in the world is trained to recognize ADHD. It's kind of an orphan condition in adults. And so people recognize what they're prepared to recognize. And that's the mood component of ADHD. And so it is very rare that I see a patient for the first time who has not been through a dozen antidepressants. And they may seem to work for a week or two and then don't, but most of the time all the person gets out of them is side effects and a great deal of frustration. If you don't think of ADHD, you're not going to see it.
Interesting, yeah. One of the things that our readers at Attitude are always curious about, and all of us are curious about, is what is going on in the brain? What do you think is the genesis of this emotional sensitivity, and how does it relate to the other symptoms, the impulsivity and distractibility of ADHD? Specific question from Norway, a clinician in Norway. He says, I've read a lot of research on ADHD, and there seems to be agreement in describing the cause as production of issues in the frontal part of the brain. But RSD, as you describe it, may be a hyperactive amygdala. Can you please explain your thinking on the biochemistry of this phenomenon?
Oh, wow, Susan. This is a whole extra presentation. Let me go through this very quickly, because we can get lost in this. We've known for a long time that the fact that these medications are mild stimulants is not how and why they work for ADHD. The evidence for that is if you feel stimulation, virtually always the dose is too high. At the right sweet spot dose, a person should not feel different. They should, it's a return to normative levels of functioning. Second piece of evidence is that people get tolerant to any stimulant side effects in a matter of days. But it is exceedingly rare that you would get tolerant to the benefits of ADHD. For an adult, anybody over the age of 16, once they find their molecule and dose, 99% of the time that is stable for a lifetime. Tolerance doesn't occur. Second piece of evidence, when you're whipping up a big batch of methylphenidate, which is Ritalin, Concerta, Metadate, Focalin, all of those, you get 4 different ways that molecule bends in space. They're all stimulants. They all enhance adrenaline and dopamine, but only one of those ways of folding in space have benefit for ADHD. The other 3 actually make it significantly worse. So just being a stimulant, having that arrangement of atoms and things like that, means absolutely nothing. It's how the molecule looks in space. In fact, there are 47 medications currently FDA approved and in the physician's desk reference that stimulate in exactly the same way that methylphenidate and amphetamine do. Only one other has any benefit for ADHD. So just being a stimulant means absolutely nothing. There was and this will be the last thing, there was a study done 20 years ago this year by Yulin Ding and Nora Volkow, who is now the head of NIDA, National Institute on Drug Abuse, where they made up 2 batches of methylphenidate. One was that one beneficial isomer, the other was its mirror image. They did PET scans, positive time emission tomography scans, and they injected this into the carotid artery of volunteers. It was pretty precious stuff, and they wanted to see where it went. The detrimental isomer just shot right straight through the brain. The brain knew it didn't want that way of bending it in space. The active isomer, there was an active transport mechanism that pulled it out of the bloodstream and concentrated it in only one nucleus of the brain. And it was right in the center. It wasn't out in the frontal cortex. It was right in the center of the brain. It's called the corpus striatum. So what does the corpus striatum do? It's your executive assistant. It's constantly scanning what's going on out there in the world. It's all your thoughts, it's your emotions. If we had to pay attention and analyze every piece of sensory data, we'd be totally overwhelmed. But this little piece of tissue can analyze about 100,000 things a second, and it sends only the one most important thing at that instant up for you to think about up there in the cortex. Everything else is handled, but out of awareness. So the place to see the corpus striatum at work is when we're driving a car. Driving a car is the most difficult thing that anybody ever has to learn how to do. And yet once we learn it, it's automatic. We don't have to think about driving a car. We can sing along to the radio, do whatever, because we know that our corpus striatum is going to keep us and everybody else safe. We've all had the experience of driving along, and suddenly there's something right in front of us, and even before we can process what it is, the corpus striatum has already handled it. Slammed on the brakes, swerved to miss it, start to question that person's parentage instantaneously. Imagine that the corpus striatum is only working 99 9/10% as well as it might. And rather than the one most important thing being sent up to the cortex to think about, it lets 4 or 5 things up there with no significance attached. That's how most of my ADHD patients describe their mental processes off medication. They've got 4 or 5 things up there at once for no apparent reason. The current thought about what's going on is that the medications that we have, just by dumb coincidence, happen to look like a naturally occurring molecule that only occurs in the corpus striatum, and that's necessary for membrane stability, nothing to do with neurotransmission. And the people with ADHD just metabolize it too efficiently, so it's a little low, and we make up the difference with the medication. That fits all the available data. Unfortunately, the corpus striatum is probably the most inaccessible place in the solar system. It's right in the center of the human brain. But at least that is the current theory about how and why the medications work, why we get the, quote, paradoxical reaction of giving a stimulant and people calm down. Is because the corpus striatum is mostly an inhibitory nucleus. It pushes all this stuff out of awareness so that we don't get overwhelmed by all the stuff that gets pushed up there. If it's not working the way it is, we get overwhelmed, flooded by all of these stimuli. So that, boy, in a nutshell, is why we think the medications work.
Fascinating. And how would that relate then to emotional response? I guess it's what you're saying is too many inputs right at the same time.
Right. The corpus striatum is designed to present us with one task, the most significant and important task at that instant in time, but only one at a time. If it's not working the way it was meant to, you get flooded with 5 or 6 things. It's like, and we've all had this with our kids. We have 5 people talking to us all at once, all demanding our attention, and it's just maddening. What the medications do is it gets the corpus striatum to work the way it was meant to, and it's basically all of these thoughts go out in the hall and line up and come in one at a time. So that it gets natural inhibitory areas of the brain to work the way they were always meant to work. It's a return to normative functioning, not an artificial state, where a person is functioning no better, no worse than everybody else, but also no side effects. That's the current theory.
Okay. Going back to the question of distinguishing between depression, especially, say, bipolar mood disorder, and ADHD, what should people look out for? What distinguishes the two? What can a clinician look for to distinguish between a mood disorder and attention deficit disorder?
Okay. You look at 6 different pieces. It's largely the time course of symptoms. All mood disorders share the following criteria. They are disorders of the level or intensity of mood, not the quality of mood, in which the moods have taken on a life of their own, separate from the events of the person's life and outside of their conscious will and control. So, with depression, with mania, the moods just happen. They're not triggered. It's not a response to anything. A person gradually loses the ability to experience pleasure and meaning from the activities of life. That's what a depression is. And it's a gradual onset. It sticks around, and then there's a gradual recovery, usually over a period of about 9 to 12 months. By definition, a mood disorder has to continue uninterrupted for a minimum of 2 weeks. With ADHD, if you ask a person with ADHD, almost always they say other people may not notice what the trigger is, but they do. They know that their mood shifts are pretty much every time triggered. Their emotional response matches their perception of the nature of the trigger. The moods shift instantaneously. In other words, the moods of a person with ADHD are normal moods in every way except one, and that is their intensity. So just because moods shift doesn't mean that it's bipolar or a mood disorder. If they're triggered, what we call congruent, or they match the nature of the trigger, they're instantaneous and usually resolve very quickly in a matter of minutes to hours, that's ADHD. If they happen very gradually over weeks to months, stick around for a year, then resolve, and there's no reason for somebody to feel the way they do, that's a mood disorder.
Okay, interesting. A number of clinicians on the webinar are asking, what treatment approach would you take to help children or adolescents develop better emotional control?
I am a firm believer in leveling the playing field. And for me, it starts with medication. The standard of care from the American Academy of Child and Adolescent Psychiatry, very clear. You start with medication. It's the only thing that we can say with any sort of assurance is going to be beneficial, and usually beneficial if you continue to take the medication for a lifetime. So most people with ADHD will benefit from taking 2 different classes. The stimulant is very good for performance enhancement, getting the tasks of a person's life done easily, quickly, and well. They're also very good for making the corpus striatum to work the way it was meant to, so that you're not overwhelmed by all you have to do. But stimulants don't do a great job on rejection sensitivity, on mood lability, on feeling hyper aroused inside. And for that, traditionally, for the last 35 years, we have used clonidine and guanfacine. It's not one or the other, it's both. Each one handles a different part of the ADHD syndrome. They're FDA approved for use together because virtually always they are used together. That gets the kid into the game on a level playing field for the first time in their lives. It's like somebody who has bad vision putting on glasses. Could they have done the classwork without the glasses? Yeah, they probably could get by squinting and stuff like that. But what parent is going to deprive their child of being able to focus their vision? The way the medications help somebody focus their attention span and impulse control. Then the person can learn their emotions because they're not always getting overwhelmed by it. It's sort of like, the kid is building a tower of blocks and somebody comes through and knocks it down and they have to start all over again. The medications keep that from kid being knocked all the way down every time. It's not good to be overwhelmed. It's exhausting. It's frightening. And the medications give you protection. The other thing is that one of the most, I think, neglected things, especially for middle school and high school students, is that they're doing something that adults have already done. They're figuring out who they are, what they are worth out there in the world outside the family, what other people like about them or dislike about them. So think about somebody who comes to this country, their 18th year or earlier. They're always going to be thoroughly Americanized. They're going to speak English without an accent. It's going to be a source of real tension between them and their immigrant parents. Somebody who gets here 19th year or later will always speak with an accent. They'll always be the outsider foreigner. What you're seeing is that we pick up our sense of culture, that we fit in, that we understand how the natives work in that period of time from puberty to 18 years of age. And if missed, it's missed forever. There's a great book out there by Michelle Novotny called What Does Everybody Else Know That I Don't? And it's for adults who just never really, because they were ADHD, couldn't slow down, couldn't pay attention, couldn't figure out nonverbal cues and that sort of thing, and become socially competent. And that's one of the big payoffs of being on medication is you've got to do that between ages 12 and 18 because that's when the brain is ready to receive it. So I always emphasize these medications are not just for school. You can do algebra anytime in your life. The medications are important after school, evenings, weekends, on dates, playing sports. Is how you learn to get along with your fellow human beings.
Oh, it's fascinating, the timing of it. Yeah. If someone with ADHD, RSD is on medication, is it at that point helpful? Can it be helpful to do some kind of therapy or other social training? In a scenario in which the person's got the other impulses under control?
Absolutely, yes. Again, it's once you're in the game, you then have to learn the rules of the game. And once you're finally available, kids with ADHD are flunking socially the way they're flunking academically. It's because they can't engage. People with ADHD are incredibly bright, capable, creative, clever people. They do a great job of finding compensations if they're in the game on a level playing field. But there's some special things that kids with ADHD need that other kids don't. One of them is when we were supposed to get new diagnostic criteria for the DSM-5, and the committee just punted and didn't do anything meaningful. But one of the things that everybody was pretty confident would be part of the new diagnostic criteria was the wording was that they had a relative lack of self-appraisal ability. Now, what that means is that for many kids with ADHD, the feedback loop by which we learn socially is broken. Most people with ADHD, and especially males with ADHD, can't in real time stand back as they're doing something, interacting, and observe themselves and say, okay, what am I thinking? What am I feeling? What tensions am I feeling? What effect am I having on other people, so that they can learn socially? What we do when we're learning how to get along with other people is we do something, we see what outcome it has. If it worked, we can do it again. If it didn't work, we can figure out exactly why it didn't work, so we can do it differently next time. Somebody who isn't able to stand back and look at what's going on can't learn. And so this is why kids with ADHD make the same mistakes over and over and over again, and are surprised each time it happens, is because that feedback loop of social learning that is dependent upon self-observation and self-appraisal isn't working for them. And so that has to be part of any therapy, any personal growth, is helping a kid with ADHD with that self-observation. Actually, on the West Coast, this would be called mindfulness. It's exactly the same thing. Mindfulness is a non-negotiable part of growing up with ADHD. You have to develop that, because that's how we learn socially.
It's interesting because, a number of people are saying, well, there must be some therapies that work with this, and in fact, you're saying yes. If your issues, say, on a level playing field, and then you tackle mindfulness, cognitive behavior therapy, whatever, sounds like it could be quite helpful, especially at that right age. It's very interesting. Yeah.
But the medications get you in the game.
Yes, right.
Then all of us, ADHD or otherwise, have to learn the rules of the game.
Right, exactly. Question from David Schwartz. David, do you ever see RSD look like OCD, that is anticipatory fear compensated for by perfectionism? Is OCD confused with RSD/ADHD in diagnosis in the same way that depression can be?
The answer is absolutely. But again, this is where diagnosticians start splitting semantic hairs, but they're important hairs to be split. In order to have the traditional obsessive compulsive disorder that we're taught in our training, the obsessions and compulsions have to be meaningless. They have a magical quality perhaps to them, but they basically sap away a person's abilities to be successful in the world. With a person with ADHD who is using structure to help them function better or to protect them from these emotional catastrophes, that is a very laudable, necessary goal and outcome. It's very productive. And so that's how you separate. Am I dealing with traditional OCD, or am I dealing with a very clever, bright person who is imposing structure on their life because they recognize they do so much better? Again, that's your acid test to separate the two.
Yeah, fascinating. A question about borderline personality disorder and social phobia. Are those also conditions that may be confused with ADHD/RSD?
Absolutely. Yeah. With rejection, sensitive dysphoria, one of the problems here is that I think a lot of the time there hasn't been a clear distinction between social phobia and rejection sensitive dysphoria, because the treatment of choice for social phobia is the monoamine oxidase inhibitors. We're probably, at least in part, looking at exactly the same things. And just it's sort of like the 5 blind men who are trying to figure out an elephant. Each one knows the part of the elephant that they see. So it is hard to separate out, and of course there's absolutely no reason why you can't have both. But with rejection, with social phobia, it's a very clear syndrome. Rarely do these symptoms and anxieties occur prior to the age of 11. You get a family history, a personal history of I was just fine until last year of elementary school, and then I became intensely anxious about being humiliated or embarrassed in public or scrutinized very harshly. Once I finally got in the situation and it didn't happen, I was just fine. That's social phobia. With rejection sensitivity, it's the realization that practically any fool out there can grievously wound me just by frowning at me. And I'd spend the next day wondering, what did I do to make this person hate me so much? The two are very, very similar. They can be teased apart. With borderline character organization, these people are very primitive. And that's what the meaning of borderline is. That the term was originally developed because either they were very, very severe neurotics who could then drop below the border, go south of the border into psychosis. And these are people who want to merge with somebody else. They over-idealize them, and then just as soon as they're either disappointed or they feel like they're going to just be completely enmeshed in this other person, then they pull away very violently. The standard book is I Hate You, Don't Leave Me. You have to read that book if you're in the mental health field. But it's that dichotomy. And it requires some time by an experienced clinician to go through, take a life history, and look at what's called object relations. How do you relate with other people in your life? Type of thing. What you find with most people with ADHD, they're perfectly normal people who can just have their entire life turned upside down by the perception that somebody has abandoned them, withdrawn from them, disapproves of them, that sort of thing.
We do have at least one person on the webinar who's overwhelmed by how accurately you were describing her life. She said she didn't anticipate that coming into this webinar, and it's pretty amazing to hear this description, I think, for many people who live with this. A clarifying question, this comes up frequently, and I think it's worth restating. The difference between ADHD and ADD inattentive. So someone asked, are the emotional dysphoria, rejection dysphoria issues seen with both ADHD and ADD inattentive type?
The answer is yes. Just to really clarify that, everything's the same. Right. Those were constructs, again, by the researcher guys, to see if certain aspects of ADHD had any predictive value about outcome, about response to medication, etc. So that ADD is the DSM-3 name when hyperactivity was dropped as a requirement for the diagnosis. As a compromise, it was put in the name attention deficit hyperactivity disorder, even though it was being de-emphasized. The criteria didn't change much at all. Then the attentive versus hyperactive, impulsive versus combined, again, that was just an intellectual construct that didn't play out. It predicted nothing. If you follow people over time, they go from being impulsive, hyperactive, to being inattentive, to being combined. And they are largely meaningless distinctions that most people have discarded. You still see them in the old books, but they're not really used that often anymore.
Okay. Yeah, we just hear a lot from people who cling to the distinction between ADHD and ADD inattentive. We should probably do a webinar on that topic because it definitely is a construct that people hold. Stimulants and SSRIs are frequently used together. Can someone be treated with the third, the alpha agonist, MAO, in addition?
No.
Okay.
In fact, two of the very specific medication restrictions, especially any strongly serotonergic medications. So that lets out all of the SSRIs. You get what's called a serotonin syndrome, where your blood pressure goes up, body temperature goes up, muscles become rigid. It's a very striking syndrome, very rare, but if it happens to you, it's 100%. So you with the monoamine oxidase inhibitors, you can't have the SSRIs, you can't have the stimulants, you can't have tramadol, which is a pain relief medication, the one and only over-the-counter cough suppressant called dextromethorphan. You can't have that one. So there's a list of medications. If people want a list of that, they can contact me through my website. Do not go on to the internet and download one of the old MAOI diets. It will scare you to death, first of all, because anything that had any tyramine at all got excluded. And we now know that those were 99% incorrect. I can give you a diet and list of medications to avoid that was just updated in January. So it's very up-to-date, very scientifically sound. Most people, if you eat a good, healthy diet, do not have to change their diet in order to be on a monoamine oxidase inhibitor. So avoid what you find on the internet.
Okay. Can you please repeat your website? I don't think we usually are careful to say it, and I don't think we did today.
Okay. You can, clinicians can send me an email directly to me. It's Dr. Dodson, DRDODSON, at DodsonADHDcenter.com. That's Dr. Dodson at DodsonADHDcenter.com. And I will send you the up-to-date diet.
That's great. I think we're out of time, regretfully. This is a fascinating topic. We thank you so much for all that you've done to bring clarity to the symptoms that many people live with and which seem to be just misunderstood in the general psychiatric population. So thank you for being here today, and thanks everyone.
Thank you.
For more Attitude podcasts and information on living well with attention deficit, visit attitudemag.com. That's ADDITUDEMAG.com.